She returns to her attending physician to report that this elderly patient appears to have viral gastroenteritis and that she can be treated conservatively in the ED with IV hydration and return to home with reassurance and to recover with bed rest. The experienced attending, however, knows that symptoms such as diarrhea, dehydration, fever, and confusion refer to a reality that is broader in scope of meaning than can be captured in the mere objectivity of their terms. Therefore, he accompanies the medical student back to the patient's room, where the full meaning of these findings can be explored and learned in the milieu of the doctor-patient interaction. Upon entering the patient's room, the attending physician pauses for a few seconds, then frowns. To confirm his suspicion, he approaches the patient's bedside. He says, "Hello, Miss Brown," and awaits her response. He then extends the tips of his fingers to touch her skin. With this, he shakes his head and exits the room to discuss his impression with the student. He says, "Your patient does not have viral gastroenteritis. She has dysentery." This distinction is important because, though dysentery presents, as does viral gastroenteritis, with diarrhea, dehydration, fever, and confusion, it is a far more dangerous condition. This patient might die of sepsis, or possibly of bowel perforation if treated only conservatively with IV fluids in the ED and sent home. The embarrassed medical student might protest that the patient had all of the objective findings that the computer said were characteristic of viral gastroenteritis. In response, the attending will give these directions to the student. When you walk into the room, smell the diarrhea. Take note of its peculiarly toxic odor. This is not characteristic of viral diarrhea. Feel the remarkable degree of heat arising from the patient's body as it fills the space around her. Look at the hue of her red-flushed skin and note its whole body distribution. You will not see these things in viral gastroenteritis, at least not in this way. Finally, he will say, note the nature of the patient's confusion. Ask yourself if she seems merely to be cognitively slowed due to malaise from fever and dehydration, or if she seems disoriented, out of proportion to what one might expect from these factors alone. Should one suspect instead a toxic effect on the brain, such as an encephalopathy arising from systemic products of a bacterial infection? The attending is therein asking the student to know these symptoms subjectively, as she would know Aunt Bessie. These considerations arise from approaching the patient from the perspective of the direct apprehension of possibility that gives meaning to the diagnostic terms. It ensures that in the future, the student will recognize the peculiar smell, fever, and delirium of dysentery. She will be familiar with them because of this anecdotal encounter. They will carry a meaning for her that they cannot possess on their own, as codified ends in themselves. With this encounter, the student learns more than just the specific findings associated with dysentery. She learns that objective findings point to a deeper reality that can be known only through the subjective encounter with possibility in the doctor-patient milieu. She will develop a healthy suspicion of computer data appearing as ends in themselves. She will know that anecdotal knowledge is not just an inferior form of database knowledge, but a different kind of knowledge, a familiarity more substantive than near data. Possibility in quality management. Due to the hypnotic aspect of metaphor, data often are mistaken as the ends in themselves in the quality management process. That is, they are mistaken as the measure of quality itself, rather than as tools of quality practice. A tool of quality and a measurement of quality are useful in the same clinical domain, but are different phenomena that serve different functions. Consider, for example, the lab test called hemoglobin A1C. That is a measure of the amount of glucose attached to a patient's red blood cells at any one time. Red blood cells live for 3 months after being born in the bone marrow. During their 3-month life in the bloodstream, they collect glucose on their cell surface. Therefore, the A1C is a measurement of a patient's average blood glucose over any previous 3 months. This measurement helps the clinician to know the effectiveness of treatment. For instance, one might assume that a medical practice, whose diabetic patients all have a normal A1C, must be practicing quality care. However, this result might reflect a decision by a medical group to discharge from their practice all those patients whose diabetes is difficult to manage, so that no poorly controlled diabetic patients remain in their practice. If the A1C is indeed the end in itself, then one must concede that this medical practice manages diabetes well. The problem with this approach is that diabetes mellitus is a disease not because of a high blood glucose, but because of the practical meaning of a high glucose to the life of the patient. For instance, diabetic patients suffer from complications such as neuropathy, immunodeficiency, vascular disease, kidney failure, heart failure, and blindness. It is management of diabetes at this level, at the level of its complications and their subjective meaning to the patient, that determines quality care. The A1C is a tool toward that deeper end, not a measure of it. The clinician might need to adjust a patient's insulin dose to address and avoid these complications, but he also might need to counsel the patient on a better diet. He might need to help her address life stresses or comorbidities that impede glucose control. He might need to adjust the treatment plan or expectations of outcome to accommodate a patient's limited resources or social supports. He might need to be available to a brittle patient after hours to help avoid hospitalizations, or be supportive of a family struggling with anticipation of diabetes-related disability. The medical decision begins and ends with this direct apprehension of open-ended possibility. Therefore, the management of the patient's illness is a creative enterprise. Quality of care is a function of this creative response. The A1C does not measure this creative response. Indeed, a medical practice that cares for poor or brittle patients, whose blood glucose values are typically erratic, can expect, on average, relatively poor A1C results. But the quality of care of this practice, as a measure of addressing human need, is better than that of a practice that merely discharges their difficult patients. So, the A1C in this case might be inversely related to the quality of care, rather than a direct measure of it. The healthcare manager who merely tracks A1C as an end in itself will mistake it as a measure of quality. It is better to have a system designed to support quality decision-making by rendering the A1C measurement available to the practitioner as a tool of quality decision-making. Computer decision-making. In all thought, there is an element deeper than the physical objects of awareness. There is awareness itself. We call this consciousness. The importance of this essay for our purpose is the question that it begs, that it is like something to be a bat, that is, that there is a distinct phenomenon called conscious. We believe that the bat has consciousness, because the bat behaves as though it is interacting with the same domain of possibility that characterizes our awareness. It responds not simply to accommodate this domain, but as if aware of this domain. The bat's apprehension of this domain might be qualitatively different from ours, reflecting a diverging path of evolution, but not a diverging source. In light of this, the problem with the notion of communicating with a computer is that a computer is not conscious. Unlike the bat, it is not like anything to be a computer. The computer does not perceive a response to the domain of possibility in which it partakes. As pointed out by the linguist, Noam Chomsky, there is nothing inherent to the algorithms and calculations of AI tools to distinguish their occasional erroneous output, designated by the anthropic term hallucinations, from inherently truthful statements, other than the human artifacts that were scanned into them, and that were at one time determined to be truthful within their own domain, a domain that now is static. Unlike human calculations, that are a real-time response to a domain of possibility in which the subject partakes, the calculations of AI are a response to nothing except to these original scanned artifacts. These calculations render a coherence to the output, but they are not a guarantor of truth. Only were consciousness nothing but calculation could this be otherwise. The plethora of anthropomorphic terms used to describe AI tends to blur the distinction between human creative response and machine calculation. The machine does not. The computer is not organically connected with the domain of possibility, as is the evolved brain. It is in no way an evolved manifestation of the universe knowing itself. Thus, there is no common ground for communicating, and certainly not for communicating a shared reference. Programming a computer to interact with a user as if the computer had consciousness, in what has come to be called artificial intelligence, does not render a state of consciousness to the computer. It renders a simulation, so that the term simulated intelligence might be more appropriate. As the computer is a tool for calculation, its substrate is called information, managed in terms of bits. To believe that calculation reproduces consciousness requires mistaking information as fundamental to the universe apart from the perceiving subject. However, information as information exists only as an anthropic tool of the perceiver. It has no meaning, no existence as information, apart from the perceiving subject. It is how the subject grasps and talks about the more fundamental domain of possibility. If the clinician turns her attention away from the patient and toward the computer, then her connection with the domain of possibility that she shares with the patient is broken. As a tool in the service of consciousness, a computer can create output that is meaningful for a conscious agent. That is, the notion of interacting with a computer is meaningful if it is used in concert with the subject's own apprehension of possibility. This is a useful role for what is called artificial intelligence in the context of the doctor-patient relationship. Aesthetics and AI. This is a good place to turn our attention to the role of AI tools in art. As many of the themes that pertain to the creative features of medical decision-making are played out in even more demonstrable fashion in the creative domain of art. It is not surprising that AI can compose a poem that will move us as does Wordsworth, or generate a digital work of art that imitates the techniques of Rubens or Rembrandt. In fact, it would be surprising if it could not. It is not surprising then that the artist and poet might perceive this as an existential threat. Clarifying the nature of AI and its natural limitations can be helpful in ameliorating this threat. In the same way that the Deep Blue computer program was created to win against a world-class chess champion by anticipating all possible chess moves. The tools of AI in art and prose are created by sampling all available human artifacts in their respective domains, then recursively creating computational routines to arrive at the demonstrably desired ends by the most exacting means possible. These desired ends in AI are derived from the already established ends, explicit or implicit, discovered upon sampling, such as the statistically likely next word in a sentence string, or graphical features created by artists and manifesting through recursive comparison with existing documents. But these are not the same desired ends of the artist who is creating a work of art de novo. For this artist, the creative urge is an artifact of consciousness. That is, it is driven by awareness, by direct apprehension of the vast domain of open-ended cosmic possibility, of which she herself is a manifestation, and that defines her role and cosmic significance. Her task is not a dispassionate calculation toward a previously determined end. It is a creative response to perception of this domain, to grasp it as an object for contemplation, in words, images, and sounds that evoke joy, grief, awe, psychic confrontation, and ultimately healing. In this way, she probes the universe for meaning and reconciliation. As the theo-philosopher Ernst Cassirer said in his Philosophy of the Enlightenment, quote, "The creation of the artist is no mere product of subjective imagination, no empty phantasm. It is an expression of true being in the sense of an inner necessity and law. Genius does not receive its law from without, but from within itself. And now it appears that this form which was not borrowed from nature is, nevertheless, in complete harmony with it, that it does not contradict the fundamental form of nature, but rather discovers and confirms this form." Close quote. So, for instance, the poet Rilke, the artist Van Gogh, the composer Handel, all were responding to what they conceived of as a sense of the divine, a domain separate from them, yet an interaction with which they sought meaning. As John Donne wrote in the 17th century these salient words that became the text of an aria in the opera, Atomic Doctor, as a petition to the divine for guidance pertaining to nuclear war. "Batter my heart, for I, except you enthrall me, never shall be free." AI can scour and sample such sources to computationally create similar works, even producing similar psychic effects for the listening patron. But AI cannot feel or understand what drove John Donne to write these words, nor intuit how this relates to the theories of Marcus Aurelius years before in his meditations on the formative role of suffering in human becoming. The tool of AI cannot know what it means to be racked with anxiety about a desire to reconcile with the universe. This is because AI is not conscious. It does not have secondary qualia, such as pain, or the experience of color or of regret. It does not feel or understand or relate or know or have any sense of being right or of becoming what it has it in it to be. When we use these terms to refer to AI computations, we are anthropomorphizing their computational activity and output with terms drawn from our own experience. For AI is programmed to satisfy these human expectations in us, with the result that it simulates them and appears to reproduce them. But, unlike a bat or Rembrandt, it is not like anything to be a computer or an AI computation. It cannot respond creatively to perception of a universe in which it partakes. The popular notion that a machine can be conscious derives from a combination of two problematic notions of consciousness, the computation and the solipsistic. The computation model poses consciousness as nothing but logical management of information that supposedly develops awareness merely with progressive complexity of computation. The second notion is that consciousness is generated entirely by the brain, with no external input, that is, entirely between the ears, solipsistically sealed off from others, and from the rest of the cosmos. Combining these two notions, it is reasonable to assume that if the same matrix of calculations that occurs between the ears is made also to occur in a machine, despite a different electronic substrate, then consciousness emerges. A very different model was imagined by Carl Sagan when he said that we are, quote, a way for the cosmos to know itself, close quote. Or when Alan Dressler observed that, quote, through consciousness, the universe has invented a way to know itself, close quote. Or when Thomas Nagel says that consciousness is, quote, the process of the universe gradually waking up and becoming aware of itself, close quote. That is, consciousness is not just awareness of the universe, it is the universe becoming aware through the agency of the evolved brain. This is not speaking metaphorically, but mechanically. The brain is that organ evolved as the channel through which the universe comes to know itself as an objective world existing apart from a subjective knower in the theater of the mind. To create such a world, the brain must be able to perceive and engage the domain of cosmic possibility in which it partakes. A computational AI machine cannot be conscious because, unlike the brain, it has not evolved as a manifestation of the universe, whereby the universe knows itself. The brain might use computation, or be thought of as using computation, in its creative response. But the foundation of this creative response, its substance, is the ground of cosmic possibility in which it partakes. This might be said to be a channeling theory of consciousness, to distinguish it from the computational theory of consciousness. However, when a calculated work of AI creates in us a sense of awe, it is not because we are fooled by it. This inspirational response attests to our own connection to the universe, and says nothing of the AI tool. Even a haphazard configuration of sand dunes blown by the wind can create an inspirational response in the right receiver. As Emerson pointed out, when we read the prose of a writer, our understanding comes from the voice of the universe through the writer, not from the writer, who is on this count superfluous. If the mere ability to evoke a response warrants the designation of art, then the calculated products of AI, no less than the artist's creative response, must be called art. But if the artist's direct apprehension and intention to communicate the content of the universe is required for what we reserve as art, then AI cannot be called art. The concern is that the illusion resulting from simulation will grow until the non-discriminating mind resigns from the human project that is called art. One will quit asking what is art?